Hello and welcome to today's Population Health webinar on Healthcare Disrupted, Strategies to Make Value-Based Care a Reality. These webinars offered by the PHA, or the Population Health Alliance, offer real-world and actionable lessons in the provider-based dimensions of being accountable for the quality, cost, and patient experience of the populations that we have the privilege to serve. My name is Jaan Sidorov. I'm CEO of the Pennsylvania Medical Society's Clinical Network for Independent Physicians, and I serve on the board of the Population Health Alliance. I'm the president-elect of the Population Health Alliance, and I'm happy to tell you that the Alliance is the industry's only multi-stakeholder professional and trade association solely focused on population health, representing stakeholders from across the healthcare ecosystem that seek to improve health outcomes, optimize medical and administrative spend, and drive affordability. The PHA and our members work together to advance the field through the establishment of standards and frameworks, elevating best practices or innovative pilot solutions, and defining the critical issues that affect our field. We do this by gathering input from leading representatives across the entire spectrum of population health management services, and we look to leave no stone unturned in our outlook. We need your help to do this. We gather virtually this information through webinars like this one and also in person. We therefore ask you to join your colleagues who are already members of the PHA by checking out our membership tab on our PAH website, populationhealthalliance.org. Look for the membership tab. Please remain with us through the end of today's presentation, where we'll be offering some unique membership discount information. Last but not least, the PHA's premier annual meeting, the Innovation Summit, is happening on October 29th, 19 days from now in Washington, D.C. Please join us for this one-day event to meet and hear from outstanding speakers in a lineup that includes folks from the United States Senate and the Center for Medicare and Medicaid Innovation, leading employers like Walmart and Comcast, and financial wellness companies like Prudential, Clarify, and Reinvestment Partners, as well as other leading researchers from Johns Hopkins and MDC. Registration can be found online, once again, at the populationhealthalliance.org website. In addition, stay on the line through the end of today's presentation. We'll be giving you some important information how to obtain unique discounts for both membership and for the registration for this important meeting. I'm happy now to turn to our speakers. Dr. Nace is the Chief Medical Officer at Innovaccer and a physician executive with more than 3 decades of senior management experience across large health systems, insurer-payer sectors, employer benefit, pharmacy, and health technology enterprises. He has served as the Vice President of Population Health at McKesson and Chairman of the Board at the Patient-Centered Primary Care Collaborative, and as a Senior Vice President at United Health Group and a Vice President and Chief Medical Officer at Aetna. Dr. Paul Grundy is Chief Transformation Officer at Innovaccer, and I'm happy to say he is the godfather of the patient-centered medical home, a revolutionary movement which was very, very instrumental in the transformation of primary care. He is the founding president of the Patient-Centered Primary Care Collaborative and has served as a member of the IBM Industry Academy. He's been a Chief Medical Officer and Global Director at Healthcare Transformation at IBM. He also served, interestingly, as a senior diplomat with the rank of Minister Counselor in the U.S. Department of State. Just a quick word about today's presentation. The slides will be mailed to you after today's webinar and are always available upon request. Drs. Nace and Grundy, it is so nice to welcome you to today's webinar.
Dr. Sidorov, thank you so much. And, you know, at Innovaccer, we are honored to be a member of the Population Health Alliance, and certainly I'm thrilled to be on the board with you and looking forward to your leadership as you come in as board chair. So with that said, this is a great partnership and looking forward to this discussion, which is so critical to transforming our healthcare in the future. So let's start off with, like, what is the nature of the problem? You know, one of the issues has been out of control costs and out of control spending. Dr. Grundy, you know, what's your point of view with all the years you've spent in healthcare as to why this is occurring?
Yeah, so unfortunately, every single dollar that could go to increase the value of being paid as labor has gone to increase healthcare cost. I mean, I think that the predominant reason really is that when you charge fee for service, you get too many services and you get too little service, and that's the core of it. So the kind of deal with the devil, so to speak, coming out of the Johnson change to Medicare was an agreement with the American Medical Association, which allowed Medicare to occur. One of the global models of healthcare, the Canadian model, where the government is the payer, but the hospitals are not run by government, was to pay prevailing rates. And what that resulted in, from the perspective of somebody like myself, who was the medical director at IBM, was that we got just a little over half of the services we wanted in terms of screening: aspirin, blood pressure, cholesterol, breast screening, colon screening, and we got many services that weren't necessarily needed or were frankly uncalled for.
So we have a movement where we see that fee for service creates unnecessary services being incented, and then sometimes they make sense, but most of the cases they don't. And now we have this movement to value-based care. So what are the levers that you can start to pull when you start to create new ways of paying and new ways of delivering care in the value-based arena?
So when we began looking at this from the perspective of IBM as a large buyer and 47 other large buyers, what we discovered was at the time that only 6% of our population could we actually buy population health. Could we get at proactively managing a population with data, i.e., really delivering that value proposition? And so we, as a large buyer, organized the Patient-Centered Primary Care Collaborative to create a foundation for moving towards that system integrator. And we began a covenant change with primary care to start that movement, i.e. we began paying them, in addition to fee for service, we began paying them for actually managing our population, i.e. making sure that immunizations were done, screenings were done, breast cancer screenings were done, and it made a huge difference. It reduced our cost by somewhere between 8 and 11% when you look at that.
So I think we often talk about, what do we pay for if we don't pay for each individual service that's provided? Do we pay for patients being satisfied? Do we pay for outcomes? How do we define outcomes? Do we pay for process measures, which has been the easier one, but that doesn't really reflect outcomes? We're all trying to figure that out, and there's a critical role for technology in trying to be able to do this. But we all know that paying fee for value instead of fee for each individual service is really where the future should be. And we're going to talk a lot about that and the role of technology in this webinar. How do we improve the quality of care? How do we reduce the cost of care? We know they can go hand in hand. So I thought what we ought to do first is let's ask our audience kind of where they are at in moving into this value-based care or population health approach. So if we can pull the poll up, we have a couple questions for you in the audience. Please go on to your webinar, go to webinar control panel, and please answer these questions as they come up. So the questions really are, is your organization at the implementation of population health management? Is every practice across your network having a robust PHM integration, working as one, taking risk? Or do you understand the basic tenets of population health management and you've implemented some aspects, maybe care management, maybe analytics? Or are you just starting to understand it, or have you not even, maybe this is all going to pass and we'll do something out? Please answer the questions and we'll pull the results up in a minute, see where our audience is at. But Dr. Grundy, I'm really curious, what percentage of, I think, the US healthcare system do you think has really taken on robust, risk-based, value-based care today?
So what we know is that 47% of family physicians are now either in a medical home that's certified by one of the certifying bodies or on the road to that. So I think we're making some progress with that foundational element, that system integrator, where you begin to manage a population from. I'm on the board of the ACGME, and the person that represents the American Hospital Association, Jay, basically said that probably about 10 to 12% of delivery systems are significantly impacting population health.
Great. Well, oh, here we go. We have the results right now. Very interesting. About 61% really have begun to implement some aspect, but only a few really are starting to take risk with a robust approach. And 23% are just starting. Does this fit with sort of your sense of the landscape, Dr. Grundy?
Yeah, it does. I think that there are many folks that are underway, and really there's three elements that they need to focus on and have to focus on. So, and the most difficult one is the first. It's the human engineering of it, right? It's the change in mindset away from opening a practice at 9 in the morning and being available to offer, help for the pain and suffering of the people who walk in, to really understanding that they have to know what's going on with their patient 24/7. And then the other thing that's really key, and that's beginning to happen, is payment change. So if you continue to pay for an episode of care, you're going to get episodes of care. There's only one way to herd a cat, and that's to move the food. And the food is beginning to be moved. But I think the third thing, and where I'm excited that we're seeing some progress, is the technology to allow that to happen, to really have the data that you need at the point of care to act on it. So you know the three things you need to do that day for those patients in front of you, and more importantly, you know what to do for those patients that aren't in front of you, and that's automated. That's just really beginning to happen, and that's really exciting.
No, that makes an awful lot of sense. And I think key to really taking on that full risk, taking on that full value-based way, even if the food moves, is understanding what you're getting into when you go to eat it. So the question really is do stakeholders really fully understand risk? We've had about a decade, with understanding from CMS, driving different aspects of value-based care, with us at the Population Health Alliance, or, us as an industry, really trying to promote value-based care and population health management. We're really just starting to understand that risk. So the questions really are, what are the barriers to fully assessing risk and then managing it? And then more importantly, we'll get into the role of technology in doing that. And I think what's more recent, just the past maybe 2 years, is understanding this use of social determinants. We're going to get into that today in terms of driving good outcomes when you're managing risk. But let's start off with the barriers. Dr. Grundy, where do you see the barriers to really fully understanding your own population's risk and then managing that?
I mean, I think that really important is a couple of barriers, right? I mean, one that I just experienced a few days ago was with my Uber driver. His wife, who was 47 and has 3 kids, had a stroke. And he had a primary care physician, but couldn't see the primary care physician because he had one of those high deductible plans, and it cost him $125 to get in and get seen. So I mean, I think we have some barriers like that really structure the prevention of. So moving towards, and as we haven't covered California, and we did an IBM, moving towards no-cost primary care, moving towards incenting people to get those basic services is going to be really important. Another huge barrier of care is the current technology we have. It's burning out our docs when they become scribes to try to get at the data. And frustrating as heck to them is when I see them at 8 o'clock on Friday evening and they're still trying to get the information they need to actually manage their population from.
No, that makes a lot of sense. And, this idea about barriers to understanding risk, we talk a lot about analytics, and people see bar graphs and lots of different data streams. What they really want to know is really insights, not just data. They want to see insights in terms of what do I really need to know to effectively make a decision about taking on risk, and trying to determine what are the areas I should focus, the value levers, if you will, that I should focus on, for really addressing that risk and having better outcomes, and really lowering my cost of being successful in value-based care.
And the other thing I should add to that, Dave, because I really work globally. I've done lots of work. I just got honored by Crown Princess Mary for the work I've done in Denmark, but I really do a lot of work globally. And what many other countries do differently than we do is they look beyond just the clinical aspects of care, and they look at the social determinants of health. I mean, for example, great paper in JAMA, I think a couple of months ago, demonstrated that in the San Joaquin Valley, we were seeing hospitalization markedly go up in the last 4 or 5 days of the pay period for those who suffered from type 2 diabetes with hypoglycemic events. They were running out of food. So, I mean, I think that if the payment moves away from a head in the bed is a profit center to a head in the bed is a cost center, we're going to have to focus on some of those issues. Otherwise the systems aren't going to be successful at managing costs.
No, that makes an awful lot of sense. And, you know, one of the things we know, and our friend David Nace is the founder of the first College of Population Health in the country and an advisor to Innovaccer. He's been wonderful. He always says, in the future, if you don't have good outcomes, we're not paying you. No outcome, no income. It's a great mantra for, I got to do this. And CMS has really recognized this. So we're now seeing population health taught in many medical schools, very new, very nascent. And I have to attribute a lot of that to Dr. Nash, who's just done a wonderful job 15 years ago in pushing this issue in academia. And then, you know, CMS has done a great job of starting to really get their arms around through iterating through different models for paying Medicare on the alternative payment models that really will bend the cost curve. And now we see commercial payers actually adopting these as well, and the regulatory environment that's allowing this. I mean, this is truly an opportunity. So the question is, if you're trying to make a decision to enter into these alternative payment models, what are most people doing around taking on risk and making decisions about it? There sounds like some people are doing it and some people aren't. And I love this cartoon, Dr. Grundy.
Oh, it's an awesome cartoon. I was recently speaking at an event where a system was pulling together all the docs to talk about moving to value and going into an ACO. And with enormous pride, they showed me the 2 new towers they just built. And they asked them the question, do you get the fact that those beds that you just put in those towers is now going to be a cost center for you and not a profit center for you? I mean, that's what accountability is about. So I mean, I think that, you know, in this particular case, I mean, what I really discovered was, you know, the CEO of that organization had retirement plans 4 years down the road, and this cartoon is just so apropos to that, right? You know, I guess it could be, instead of discussing on this call healthcare changes, we could be discussing the change of delivering goods 100 years ago, where people were arguing about whether they should reshoe their horse Daisy or buy this newfangled thing that didn't have a horse to deliver their goods. And frankly, those people who invested in reshoeing Daisy, they might have done okay for a couple of years, you know, but 15 years later, they were out of business. And we're already seeing that happening across the United States in places where managing risk is really being invested in versus fee for service.
No, that's great. So I love this Moody's. You know, it really is more specific, and I love the cartoon, of course, but Moody's is very clear that if you're going to start really taking on risk, you really got to understand how to detect, monitor, assess, mitigate, and prevent risk, and that means data. And in order to get that data, you need solid technology. That's really the key, and that's what people are struggling with. Like, what do I buy? How do I do it? And how do I make it useful in the world I'm going to operate? So I think behind all of this, the push, really going back to CMS, is last December, end of the year last year, said MSSP, which is the Medicare Shared Savings Program, really was reshaped into this pathways to success to say, no more shared savings. Shared savings is going to be an on-ramp to take on risk, period. That's where everybody needs to move, and they need to move there quickly. So the analysis of this on the Medicare side is it's going to save $2.9 billion over 10 years. That's huge. And so this is very interesting. With the payment changes we see of moving everybody to risk is going to really change the landscape. And we see the private payers, you know, I've been working with the nationals and the locals here at Innovaccer. They're all saying the same thing. They're going to follow this lead as well. So finally, we have the gauntlet thrown down. We have Medicare leading really the issue by empowering moving people to risk, and now we see the private payers following. So we really expect to finally see this change. It's so exciting.
And
So,
David, this is really the biggest change that healthcare has confronted since Flexner wrote his report in 1911. I mean, it's just a huge shift. And that human engineering and that payment reform and that technology, that evolution of that over the next few years, where, you know, AI and information technology is going to do for the doctor's minds what imaging has done for their vision. It's really going to make it clear what's happening to each and every patient. They'll have a plan, and much of it will be automated.
absolutely. And, you know, I have here a slide. It's a little bit complicated, but it really describes some other aspects of what we learned around taking a risk. And in many ways, it's kind of good that CMS sort of delayed the gauntlet throwing, everybody moved to risk issue until now. Because what we're understanding is that only 10 to 15% of the outcome of population health is driven by the clinical interventions we do. Maybe 20%, but probably 10 to 15. The vast majority, 80%, is done in two sort of buckets. One is these social determinants of health. I think, Dr. Grundy, you alluded to it earlier, is that when you run out of food, you got an issue. You got to make decisions if you're diabetic. Do I take my meds? Do I pay attention to what food I can afford? And obviously, the healthy foods are often inaccessible or not accessible. We can do the same thing about, can I get transportation to my doctor? Do I comply, and can I even afford the medication? You know, how safe is my environment to go out and exercise, go for walks if I'm trying to reduce my weight? These are tough decisions that from a clinical standpoint, we've not really embraced and been involved as clinicians in the past. So now we see, and this is our friend David Nash often says this around the bottom here, providing clinical care, is that we have to move upstream to where into more prevention. We have to stop mopping up the floor and go upstream and turn off the faucet. I love that quote. Because what we've been doing is mopping up the floor for the past 50 years. So now that we begin to understand this, we can do a couple different things. And we're going to talk about some case studies that have done this. First of all, we can start to address social needs. We can start to understand them, assess them, try to understand them better, and how to screen people and then inform people and leverage the people that are experts at addressing them in the community, like social workers. And then lastly, we can start to work with our community, because every health system, every doctor works within a community, and start to address the issues of safety, safe food, good food, healthy food, transportation for those people who need it, and collaborate. And this is the key, the collaboration of clinical care providers with the community to address these issues, and with community providers. And so it's very interesting. You know, we had a discussion with Dr. Nash recently, and one of our partners, Humana. And it was one of our, Andrew Renu, who's a medical director at Humana, brought up in a webinar we did recently that had just come back from a conference, who had suggested that we create a new specialty in healthcare called upstreamists. People, physicians who are experts and trained in how to address things upstream. So Dr. Grundy, does this fit with your experience over the world about our need to address these things to really understand and address the risk of a population?
Absolutely. And we have some very interesting examples right in the United States. I mean, without even going to England or Denmark, but in Vermont, the Blueprint for Health, which was started, I guess, about 15 years ago by Governor Douglas, took 2 cents out of every sick care dollar and created the role of a community coordinator. And that community coordinator pulled together all of the social services and the public services, you know, to sort of create a plan around every patient. So our newly diagnosed diabetic, for example, would be taken to the diabetic hiking club that would meet on the weekends, that was made out of the old rail trail, would be taken to the grocery store where the nutritionist would do a walkthrough. And then once a month, all the public agencies and not-for-profits would gather together and really create a plan. And there was this young Anglican priest, and she stood up and she said, never again will we allow a diabetic to suffer an amputation, because we as a community don't have a plan around them. And we have seen in that community, in St. Johnsbury, one of those 11 communities I happened to visit, we saw a 60% reduction in the complication of our diabetics. But, you know, we're seeing a whole lot less strokes. We're seeing, you know, a significant focus on asthma, blood pressure, cholesterol, and really 1/3 less need to do heart surgery. And I mean, that's the sort of mechanism. And I see that happening all over. I mean, I see communities where the YMCA is playing a key part, Meals on Wheels. In one community I visited in Jersey, the mailman was stopping and checking on the patients every day because they went to every house every day who got discharged from the hospital, who had special needs, frail elderly, et cetera. So we're beginning to see that happening even here in the United States.
And you know, you and Dr. Grundy, you and I at Innovaccer have been working with how do we actually empower our healthcare clients to really close the loop in bringing the community providers into the world of the healthcare providers, so that physicians, their teams, care teams, their primary care teams are starting to work directly with the YMCA, with the Postal Service, those specific areas in their community where they can broker those relationships and start to leverage them for specific high-risk patients and how to address their needs. So this is just a tremendous slide, really educate this one, the world we need to move into. And it's so new. We didn't learn this in medical school. So I think the big question comes up is what's next for population health? Really, what's going to happen next? And I think sorry about this, I had some problems here with the slides, just kind of moving back to the question we asked, what's next for population health? So, you know, Dr. Grundy, I know you brought up this example that 10 years ago, patients frequently went to emergency rooms for ambulatory sensitive conditions. They had an issue, heartburn, they fell, whatever, and they went right to the emergency room. And when they got there, the physicians really had little insight into what impacted that person's healthcare condition. So the question is what technology advances will identify the risk related to non-clinical factors, these social determinants, and who will build these alliances, and how will we activate the data? Now, Dr. Grundy, I remember you and I have been friends and colleagues for a long time. You know, when I was at McKesson, you were at IBM. And then more recently, we were getting together talking about kind of different things that I had learned about technology here in Silicon Valley. You might want to share a little story about that.
Yeah, I mean, I was so excited when I began to understand that, you know, there were actually breakthroughs that occurred. Some of the stuff that I tried to do at IBM and I didn't succeed in doing was really about a fundamental difference in how you look at data. So getting at the data first, like Google Map does, being able to project that data to you so that you actually know not just what a city map looks like, but that you're going to turn right at the next red light to miss an accident. I mean, that sort of change in information. But the other thing is that when you begin to mine information out there about what's happening down to the zip code and what's happening down to the census tract level, and you begin to understand, you know, what your patients look like, it can make a huge difference in terms of, I think there's like, in my community, it's like 186 publicly available sources of social determinants of health information. If you pull that together and you present that into the clinical system as part of the risk of what you're confronting, I mean, the likelihood that you're going to be successful in a world where a head in the bed is going to be a cost and not a profit to you, it just is going to be so much easier. And so I think we're finally beginning to get at that. And then linking that into the community resources that exist out there. And again, in my community, there are actually 32 sources for food information. There's many sources for transportation that can be made available.
Now, that's awesome. So let's get down to a specific example and really compare and contrast like how this plays out at a patient level. So this is a great slide. We can have two people, type 2 diabetes, one person's pretty healthy and the other person's not healthy. What really makes the difference? How does this tie into what we've been talking about social determinants of health, Dr. Grundy?
Yeah, so that goes right back to this example of our hypoglycemics ending up being hospitalized in zip codes where they're running out of food. When in fact there's probably many resources that people could rely on. I mean, it's just so important that you know, I mean, gosh, I mean, I just don't think you're going to really effectively treat an asthmatic that doesn't have a coat and lives under a bridge. I mean, you really need to pull those factors in.
Yeah, I think about the old days that I was doing primary care. I would walk down the hall, grab a chart, go in, see the patient, say hi. I might have actually listed a few things like their birthday or their son's graduating from high school, whatever, just to make that personal connection. But I would not think or even know about their environment. I would not think that one person that I walk in who had diabetes really had a safe environment, had access to safe food, what kind of food they ate, whether or not other people in the household were smoking. I would only ask them, do you smoke? Do you not smoke? Usually give them advice that never worked, which is you ought to stop, and that was it. But, we really need to start understanding this information. And sometimes patients are reticent to share it. So it's all about data. How do we collect that data? How do we collect data in terms of their home environment, where they live? What are the issues that we can then ask them about because we know about it? And then also collect data in a safe way where people may not be so reticent to share person to person, but we know that people generally are more honest and more willing to share personal and concerning information by electronic means. So how do we think about capturing patient-generated data, 24/7 access? How do we do it in the waiting room by giving them an iPad? And how do we match that up to what we know about their community and the social, environmental, and economic drivers within that community? It's so important to deal with this issue. And then we can really...
In one example, David, I was really fascinated. One of the folks that we were working with in Iowa at Innovaccer actually does this, and they take that mega information down to the individual patient level once it's processed with 4 or 5 questions that you could ask. And I thought it was going to be bothersome to the patients because these are kind of personal questions. And I found the exact opposite to be true. I sat in the waiting room and watched them working on one of these pads, and they were so pleased that their doctor cared enough that they wanted to know if they had transportation or food problems, right? I mean, I just think it adds another level of trust in that relationship of trust we're trying to build.
No, and I think this is a great slide that really shows about how do we start to bridge the gap between clinical and social needs. We need clinicians that are connected to skilled nursing, long-term care, hospital care. In fact, I was talking to one of our customers this morning that does pediatric in-home care. And when they walk into the home, and I remember this when I did emergency services as my 2-week stint in medical school, I learned more about a patient when I walked into the home for an emergency than I could ever learn in a clinic. I would be able to walk in and see how messy the house was, how safe the environment was, the condition and neatness. I would be able to open up, and I learned there were 2 sources for this. One is one of the cabinets in the kitchen or under the bed in the patient's bedroom is usually a shoebox full of prescriptions. And I'd be able to pull that out and quickly determine how many providers they saw, what their diagnosis most likely were, how compliant they were by looking at the dates of the medications, how complicated the medication regimens would be, and then whether or not, they were able to actually manage them. And then I'd look around, I'd meet the family members, I'd see how they interacted and how collaborative they were, or supportive they were. There was so much information, as Malcolm Gladwell often wrote in his book, Blink, that I could see in just the glimpse of walking in within a few minutes. And this is so critical because historically, we're completely blind to that information in the clinic, the way we've practiced medicine in the past. And it's so critical in terms of building trust and keeping people from just constantly going to the emergency room when they have a problem with very little information there. So with that said, we start thinking about how do we start to address these social determinants across a clinical enterprise. So, Dr. Grundy, you were just giving an example when you were in the waiting room. What are your thoughts about how we start doing these pilot programs to learn and then scale them across a clinical health system or a network or a practice?
I guess, thank goodness that we're moving away from the concept of Flexner that the data storage devices the doctors had. And now that we're going to have data, we can actually have a team approach to care, just like the way we build a skyscraper and no longer cathedrals, right? So, you know, where I see this working well is that there are community health workers. It was really fascinating. I was in a system down in North Carolina, and what they did is they reprogrammed their janitorial staff to be community health workers because they knew the community, right? And these guys just felt so empowered because all of a sudden they had a much more important role in the community. And so they can be some of the gatherers of that information and really relate to the community in a different way. I just think it's real exciting that, you know, now that we really we're gonna have a plan, right? Just like we do a skyscraper, it's gonna be, the data is gonna be stored in a computer that works, and not in your head anymore. That we're gonna really change the way we interact. And I think the other thing that's really gonna make this powerful is our iPhone. We have a whole nother way of reaching out to people and engaging them. My kids who are in their 30s have never seen a teller in a bank. They never will, right? So, and I think these kinds of changes are going to dynamically impact, you know, how we deliver. One of the things that I hear often, you know, when I go in to see doctors is this is not my job. I don't do this. And I think they're partially right. I mean, I think the two things that a clinician should do is difficult diagnostic dilemmas and relationships. So in that diagnostic dilemma problem, that's, you know, but the relationship problem, as you pointed out, Dave, you know, some of this could really enhance that relationship, I think.
No, absolutely. And, you know, it's really all about a team. You and I, when I joined you arm in arm, when we were driving this patient-centered medical home movement in this country, you know, one of the key fundamental principles is it takes a team and you have to work as a team. So I agree. A physician has a core competency. They have an area that they can sort of address, but they need to work as a team and a quarterback of that team. And that team can involve people like community health workers, social workers, nurses, people that go into the homes, and really focus the people on those that need it, the high-risk patients, to really effectively manage a population. Just yesterday, I was on the phone with Sarah Scholey's team at the NCQA, and it's very exciting. They are trying to create quality measures from NCQA standpoint for these social determinants. And they're trying to figure out the best way to do that. And Dr. Grundy, you know, we at Innovaccer did this probably 2 years ago. We began a social vulnerability index, and we used machine learning to really rapidly use regression analysis in multiple different ways of weighting social factors, including things that we could pull off of Google Maps, where we can see the landscape, restaurants, food access, safety issues, stuff from public sources, and then map that against outcomes. Well, we have publicly available data on outcomes, Medicare data, Medicaid data, and then reiterate that through machine learning and really identify the right weighting and the right factors to identify down to a zip code or census level track the exact nature of the risks where a patient resides.
And you know, so when you hear the word AI or machine learning, I mean, I think many people still think that this is some sort of magic. It isn't magic. I mean, by the way, we're using it every day when we use Google Map and when we shop on Amazon and all these other things. I mean, just the power of it is phenomenal. And the reason why it's phenomenal is that we have some limitations as human beings. We can put 6 or 7 things together and it'll sort of sort it out. But with machine learning, you can have millions of factors that you can begin to sort out and look at. So you can really hone in on some of the issues, as you all realize when you get targeted by Google or Amazon. I mean, you know, we can really understand by looking at the patterns that a woman with 3 kids is most likely going to respond to a message that we need to give them after 8 on Tuesday. I mean, that sort of pattern ability is going to change how we can engage our patients. And then pulling together, I mean, for example, just Google Maps. I mean, you think about, it knows where all the grocery stores are, it knows where all the liquor stores are, et cetera. I mean, that information is all out there to be utilized to support our patients.
And for those of us that have been working with people with AI teams, and I work with a lot of machine learning engineers, what we learn is really what artificial intelligence is about. It's about really 3 levels of bringing information from these new data sources and these new kind of machine learning where the machine is actually trained and begins to learn just like a human learns, but really provide information to someone in 3 categories. One is providing an insight, not just data. So Google Maps is a great example. You're driving down, or Waze, driving down the road, and you don't want to see bar graphs and various data feeds and predictive analysis of average speeds of velocities or predictive value of whether or not what's ahead is an accident or not, because it really doesn't know exactly. It pulls in various things like police reports and the way the traffic slows down. All you want to know is an insight, which is if I turn right and take this route, I'll save 4 minutes as opposed to going straight. And that's new information. It's just an insight. So that's the first level of AI. The second level of AI is actually providing direction from that insight. So we've all used Waze. It'll often give 3 different paths, right? Turn right, turn left, you'll say 3 versus 5. It gives you an insight, but then the second is actually giving you a specific direction, saying this is what you now need to do. And then the third arena of AI is really making that decision for you. So as we think about self-driving cars, we can automate much of what those insights and directive insights actually provide. Those are really the 3 levels of AI. And we see that for those who have Teslas, and when you let the car do parallel parking all by itself, it's taking the actions, it's taking that 3rd level. So what does that mean for healthcare? And what it means is that there are some things that can be automated, there are some things that can't. It's a relationship trust environment. Some things that we just need to provide people insights, but we gotta pull people away from this, having physicians be data recorders for billing purposes and looking at the machine instead of looking at the patient. We really need to free them up with a few insights so they can spend time, just like when we use Waze in driving a car, they can spend time with the patient and just have those insights they need to do so they can work on that relationship. I think that's your experience too, Dr. Grundy, correct?
Absolutely. And what excited me most about Innovaccer when I first learned about it from you and went and saw it in action with the clinicians was that, the average physician, when they had that information popped up without them having to it was saving them an average of 3.2 minutes of time per patient. I mean, it just begins to bring the joy back. So, I mean, I really think that as we move out of the information age into the age of intelligence, for the first time, it's going to do something for us, because I think the information age kind of failed us because healthcare was just so much more complicated than launching a rocket to the moon. I mean, it's just beyond rocket science. But it's going to do for our minds what imaging has done for our vision. It's going to make it clear. I mean, ideally, when you click on a patient, the 3 things that you need to do for that patient today is right there in front of you, just like when you look at Google Maps and you have to decide to turn right or left.
So let's take that example of what you just described when you were in the waiting room, because I know exactly where you were. One of our clients, and it's Mercy Health, because they recently did a webinar with us. They take that number 2, that zip code level risk information that we're able to pull from various sources with machine learning to give very accurate, specific directive about what the social, environmental, and economic risks are for the patient. And then they integrate that with the patient-generated data that they do from a handheld, using people's smartphone ability to collect that data. And if they miss it, they collect it with a pad in the waiting room. And then they integrate that and use machine learning to really start to individualize the risks for that patient within that zip code level. You have to have that zip code level, and you have to have that patient-generated data, and then be able to stratify those patients. So 1, the practices know the people to work on in terms of risk, but when they walk into the clinic, the patient has, the physician has those insights in how to address those risks. And that's, I think, what you saw when you were there.
Absolutely. And what really excited me was that it enhanced the doctor-patient relationship with trust. These people were not worried that the doctor was asking inappropriate questions. They just really cared that their medical team cared enough about them to wonder and worry about some of these social needs.
So enough about us. Let's turn to our audience again and see where they're at in being able to understand what kind of data they need and what kind of data they have. So if you all could turn back to the chat box and be ready to answer into this call, and let's bring the poll up. What troubles your doctors most in their daily work? Do they have limited data to the right patient data that they truly need to manage population health, to manage risk? Are there unnecessary administrative activities taking too much time, such as been written up in recent reports like death by 1,000 clicks and physician burnout because of the EMR? Are there limited resources to interact with the patient? I don't have people that work in the community. I don't have community health workers. I don't have people in a team to be able to do these things. No one affords me to do that. They just want me to see patients. Very fee-for-service mind shape. Or are there complicated IT systems? Lots of different systems I have to pull up. I have to hunt and peck around through different systems to find the information. I'm not talking to the patient. My back is to the patient because I'm looking around in the computer for the information I need. What are the key factors here? So, you know, Dr. Grundy, you and I have been dealing with this a long time. Physicians really are frustrated, aren't they?
Oh, it breaks my heart. I just so, you know, when I see a physician, you know, basically being, you know, doing something that should be paid $20 an hour instead of $200 an hour as a scribe. I mean, it just seems like such an amazing waste of time. Again, two things they should do: difficult diagnostic dilemmas and relationship. Everything else should be done by somebody else, probably more efficiently and more effectively. And certainly we need to help them get the information they need more effectively. It's just really frustrating for them.
Yeah, I think as one of our advisors had said to us recently, he said, what we need to do is uncouple the shackles the doctor has to the EMR and let them work with the patient. All right, so let's pull up the data and see what our audience says. Very interesting.
Yeah, exactly.
So what do you make of this, Dr. Grundy?
Yeah, I mean, that's what I see every day. I mean, we really need to take that green line that almost goes to the end down to next to nothing. And I think that's entirely possible. I think so much of this needs to be automated, and so much of it needs to be done, you know, by a team of folks that are collaborating together and everybody working at the top of the license. And I'm in my 15th year, I think, as a faculty member at the University of Utah. We have 2.2 MAs for every physician, and those MAs actually operate the EMR. And I'm seeing that happen more and more, and it really frees up the doctor to the time. But I think the technology to have that information at the point of care and then acted on by that team, starting with the person that's calling to see that the patient's going to come in for their appointment, and they have that information and they can actually order the test then, et cetera, is going to be really important.
Great. So let's go back to the webinar presentation and talk about the fact that it's really not just about technology. It's really about the physician as well. So if you can just move this slide to the next slide. My apologies. Having a little technological struggle here, and I think that's really the key point, is that technology is not the only answer. We need doctors too. And I love this picture from the New Yorker where you can't list your iPhone as your doctor. You actually have to have a person, right? So one of the questions we often ask here at Innovaccer is, can modern technology enhance the human side of health? You know, one of the things that we've learned from our friend Dr. Steve Plaskow at Jefferson Health System, who's been really working with us very closely as an advisor, you know, he often says AI really is not about artificial intelligence. It's about augmented intelligence. How does technology, or as he often says, how do robots and humans learn to work together, right?
Absolutely. That's the way of thinking of it. Absolutely, Dr. Nace.
So in the early days, you know, healthcare was really focused on the doctor-patient relationship, and that was it. And now we have EHRs that came as part of the stimulus plan, and we thought that was going to solve things by digitalizing a billing machine, and they've really been a bit of an impediment to the relationship. So the key is, how do we bring technology, just like a good example that we use, like Google Maps, or those of us who use other things like LinkedIn and other services, that when we buy stuff through Amazon, everything's easy. It shows us what we bought before and what we liked, and you know what makes sense for us given our pattern, because it learns about us. How do we bring augmented intelligence to bring that human focus back in the relationship and trust in what we know as primary care is the foundation of healthcare going forward. So in the future, technology will augment, not replace, the human side of the care team. And I know, Dr. Grundy, this has been so true to your heart as the godfather of the patient-centered medical.
Absolutely. I just am really optimistic that we're finally beginning to make some of the breakthroughs that we need on that technology front, the third leg of the stool, right? The human engineering, the payment redesign, and the information age, the information age moving into an age of intelligence where the actual information is there.
No, that's great. And so as we get toward the question and answer part of our webinar, please go into your chat box and start to put some questions. And as we get toward the end, we'll start to bring up those questions and have a dialogue about them. So I love this quote from the Hippocratic Oath on Artificial Intelligence by Oren Etzion, which is, "My AI will seek to collaborate with people for the greater good, rather than usurp the human role and supplant them." This is the struggle we're dealing with in healthcare now, is how do we use technology to make the human relationship a better relationship, so that trusting relationship, the healer, will really play the role and be augmented by technology and not pull people away into just interacting with only the technology. They need to supplement and really enhance the ability for the clinician to work with the patient.
One example of that, David, is one of the systems that I visited recently, which was really, really impressive. And the technology allowed that any encounter that happened in that system, no matter what it was glasses being picked up or medication being picked up or front desk encounter, what would happen is as the information about the patient was brought up, the first thing that the person would say, no matter who they were, the MA or the dentist, would say, "I see that your doctor is Dr. Gonzalez. Dr. Gonzalez cares about you." And Dr. Gonzalez would want, so they just continuously reinforced, because they had the information there to do that with, they continually reinforced that relationship of trust every time they had a chance.
No, that's so important, and that's so spot on. So, you know, I have an interesting story, and Paul, you've heard this from me before. You know, it's a little case study about how we can, as a team, rethink the way we deal with these issues of social determinants of health and moving away from traditional fee for service, how we work as a team, and who that team should really be, and how do we use technology to support it, particularly evolving technologies that really help us really augment our relationship, not replace it. So, you know, I was working with my good friend Rashika Fernandopoulos, who was trying to create a new healthcare approach for very high-risk patients. And before he started the company Iora, which is doing a fabulous job, really innovative primary care, you know, he was working with done some work that we were working together on the Boeing project many, many years ago. Started doing work in Atlantic Care, which is a group of gambling institutions where the culinary union was trying to address its really complicated healthcare system. And for those of you who may have been to Atlantic City and know the gambling community, it's an interesting community of folks that work in the gambling industry. And in that neighborhood, there are many pockets of different, you know, Laotian communities and Vietnamese communities and, you know, Japanese communities and Spanish communities. There's all these different, you know, hodgepodge of different communities who speak different languages and have different issues within their communities. So they were like focusing on the highest risk patients. And they said, okay, look, we got it. We're going to be innovative. We're going to take on primary care practice in a new way. They hired new team roles like care coordinators, coaches, health educators, community health work. They thought they were right on the cutting edge. And I was going back and forth and meeting with them from time to time. And I thought they were doing the right approach. And so they hired all these people, and they found they just weren't having the impact that they really thought they were going to get. And they realized they had an engagement with the patient issue and the community issue. So they did something innovative. They said, let's bring in the patients, these very high-risk patients, and they've been working with them. They've had people going into their home and community outreach workers, and they said, let's ask them, like, what are we doing wrong? Now think about that. That takes a lot of gumption for you to bring in a whole patient population and say, we don't think we're doing a very good job as a practice. What are we doing wrong and what should we do? And they said something very interesting. They said, you know, these people you're hiring all clinicians and nurses to do these new roles. They don't know our community. They don't speak our languages. They don't know our issues. It's hard to trust them, and they just don't even understand how to communicate with our community. They don't know the resources we have. So they then said the most important thing. They said, what should we do? Who should we hire? It's funny, they were quiet for a while, and then one said, hey, you ought to hire Lizzie. Well, who's Lizzie? Well, she's a 20-year-old. The family can't afford to send her to college. She's working at Burger King. She's super smart. She's a social connector. She knows everybody in the community. She speaks 5 languages. Like, everybody knows her. So they did that. They brought her in. They trained her, you know, to do, be part of the team, to work on the team record. And what they suddenly found is that the results they were looking for started to just come forward. And I actually went with the team not knowing they had done all of this, and met in their rounds where they had 7 of these community groups, these community workers around the table doing morning daily report with 2 doctors and a pharmacist. I thought they were master level clinicians because they were doing a medical model report. They were integrating social stuff with clinical stuff. And when I found out their background, I thought, my gosh, you know, you really have to rethink the way your team is in the practice that you're delivering. Just a great analogy of how one can rethink what they're doing in terms of addressing this risk. So, you know, Dr. Grundy, I think the future's here now. We got Medicaid, Medicare moving us into risk, everybody into risk over 10 years. We've got private payers doing that. We've got new technologies available, like we're giving in Innovaccer. Where do you think, how much do you think this is going to fulfill the dream?
I think if we focus on not reshoeing the horse daisy, we're going to be better off and not out of business. I honestly think that we're really at the cusp of beginning to get at the covenant change, really, between those who want to buy care of value and those who want to provide care of value, away from delivering episodes of care to proactively managing a population with data.
Yeah, that's great. So, you know, we're kind of getting close out of time. I haven't seen a lot of questions come in, so I'm going to turn it over to Dr. Sidorov to see if there's a question from the Population Health Alliance.
We do have one question. Both of you mentioned that, I'm going to paraphrase things. The both of you mentioned, you know, the greatest barriers that face physicians in overcoming and being able to apply the necessary bandwidth to population health in the dawn of a new age in achieving outcomes for the patients that we're privileged to take care of. Basically, the question is whether or not there are 2 competing models of healthcare out there. One model is that healthcare providers, and specifically physicians, are exquisitely trained to take care of patients with multiple complex medical problems, systemic lupus, Wegener's granulomatosis. I'm flourishing the question here a little bit, but doctors and patients in the traditional doctor-patient relationship, and the rest of the stuff of population health can be adequately managed by a quote-unquote healthcare team. The doctor's still the quarterback, let's say, but there are other members of the healthcare team that can do much of the heavy lifting of population health, versus another healthcare model where doctors are assigned to a cohort and they preside over their patient population, much like officers in a public health context, and they spend a lot of time, not necessarily seeing patients one-on-one, but they spend more time managing a patient population as a supervisor. Are those 2 models mutually exclusive? How do you put them together in the real world of me, the primary care provider, having to take care of 2,000 patients?
Paul, you want to take that first?
I'll be delighted to. So I guess the future is now in some places. I just got back from Denmark, where they really they've gone from 120 hospitals down to 21 in the last 2 decades that I've been working with them. And the first model is really the key. So they redefined what primary care is. Primary care is the role of the comprehensivist with their team. So they're capitated, they're paid on how well they service their patients. and they manage a population, and they provide 93.7% of all care in the Danish system. Those folks that are hospital-based and provide those high-end services are referred to as partialists, and not lovingly so, right? So you've got comprehensivists and partialists. So they specialize in a part of the body, but there's that flow between the team. You know, everybody has their primary care doc, everybody has their medical home, and that flow of information, that dynamic flow occurs.
And the only thing I would add to that, Dr. Sidorov, is that it's all about innovation. I think people need to try different things. Different things will work differently for different teams in different communities. What we need to do is collaborate and share these information. And this is exactly what the Population Health Alliance is all about. How do we bring together people that are really at the forefront of population health management and learn to share, given a safe arena for us to join, give a collective voice, give a strong foundation, learn from each other, try new models, iterate, learn how to be successful, which may be unique in each community. So I want to really thank you for helping to sponsor this. I know us at Innovaccer, Dr. Grundy, the whole team is thrilled to be a part of Population Health Alliance. We're just very excited about the upcoming conference and the leadership that you've provided at PHA.
Thank you, David. Everybody who's still on the line, keep an eye on your inbox. There'll be a specific discount code that you will be receiving in your email. Please use that email, and also please, for those of you who are not members of the Population Health Alliance, to think about joining us. We are stronger as a population health community with you than without you. This is obviously an audience that seeks to lead, and you know, our time has come. Population health is no longer an optional thing in healthcare. Thanks to companies like Innovaccer and other members of the Population Health Alliance, this is a movement that is only destined to grow, which I find very personally satisfying and great. And if you join us, I think you'll find that to be the case also. We are at the close of the hour. Unfortunately, we can't get to the other questions that were asked. David and Paul, what we'll do is we'll forward those questions to you so that you can respond to them individually. A bunch of them came in at the last in the last minute, if that's okay with you. And as I mentioned to everybody, we will be holding another. We will be providing you a copy of the slide set upon request if that's what you want, if you don't get it as part of this webinar. Last but not least, I want to point out that we'll be holding another webinar. We've been doing these on mostly a monthly basis. The next one will be held on November 13th, so please mark your calendar accordingly. David and Paul, do you have any last-minute closing remarks to make?
Just a big thank you for sponsoring this, and a thank you for all of those of you who came, and the 300 people that are still on the line a few minutes after. Thank you.
Thank you very much.
Yeah, great. Thank you. This ends the webinar, and we'll be seeing you in approximately a month. Thank you, guys.
You guys.